Dear colleagues, good afternoon. Let me introduce myself. My name is Fiori. I'm professor of urology at the University of Turin, Italy. Let me say that it's a pleasure and honor to be here with you for this interesting webinar on endoscopic enucleation of prostate. As you know, AEEP is gaining widespread acceptance worldwide, and we can say that today AEEP is challenging TURP as gold standard in surgical treatment of BPE, thanks to the excellent outcomes in terms of efficacy, safety, and durability. From the historical point of view, there is no doubt that Hall has traced the path, but in the recent years, other techniques based on different sources of energy have been proposed. Today, we count on different lasers such as holmium, thulium, superthulium, green light, but we have to remember that we have also monopolar and bipolar energy to perform enucleation. And in other words, the terms AEEP should be used to define the concept of energy-independent enucleation of the prostate. In the EASU webinar, an outstanding faculty that I can share you will focus on technical details to perform a successful enucleation and on clinical results of AEEP. As one of the main drawbacks of the enucleation technique is learning curve, different training models will be discussed too. Here you can see the faculty is an outstanding faculty. I think there is no need of introduction because each speaker is very well known in the urological community and has a huge experience in the field of AEEP. Here we can see some practical information. Every speaker has 15 minutes for presentation. Question can be asked through the question portal, so use the Q&A section. We will be happy of your questions. And this webinar is accredited with 1 European CE. So I would like to speak as little as possible. So I ask the technician to play the pre-recorded presentation of Fernando that is joining us for the section for the discussion later. Please.
Hi, hello. This is Fernando Gomez Sancha. My talk today is to describe published techniques to perform anatomical enucleation of the prostate, similarities and differences. I have been a consultant for Luminis and Quanta System, and I am a consultant for these companies. So if you look at the task they have given me today, there are many different energy sources with different wavelength, lasers, bipolar, monopolar. There are different approaches, 3 lobes, 2 lobes, 1 lobe within an incision and block early or late apical liberation, anatomic techniques versus non-anatomic techniques, mechanical energy versus dissection with energy, mechanical dissection versus energy dissection, and then the personal touch that every surgeon gives to their operation. So I would like to bring the figure of Spock, who had this idea of infinite diversity and infinite combinations as the basis of the Vulcan philosophy in Star Trek. There are infinite diversity of techniques and combinations, and the number of publications discussing surgical technique are overwhelming. And I have to say, there have been many contributions from many surgeons who are passionate about what they do and who are trying to communicate their ideas so that the rest of the world can know about this and act upon them, implement them in their practices. This is a very nice paper where Peter Gilling and colleagues describe the history of prostate enucleation, and you can see that there's different sources of energy and different ideas published over the late years. And I have to say, I apologize if I'm not including someone's work in this presentation. I am focusing it to highlight some ideas that I think are important, and I apologize if I don't include the work of some people. Of course, we have to acknowledge Hiraoka in 1983. He was the first human being to perform an endoscopic enucleation. He developed a special probe to do that, and he would do an en-bloc enucleation with the assistance of the finger in the rectum, which was common in open prostatectomy at that time. He published very little information about the clinical results of his technique, and he was largely ignored until Peter Gilling and Fraundorfer described the classic three-lobe technique for HOLEP. This has been the main way of performing HOLEP over the last years, and many people who have used other lasers, other sources of energy, have used a similar approach. It is the technique that has biggest amount of materials to learn and to teach. Some of the teaching resources are based on this technique, and it has been the most widely adopted. But this technique was a little bit difficult to learn. It had a relatively long learning curve. And of course, there was a high risk of temporary stress incontinence. Some centers would show 39%, 16%, 10% at the beginning of, and then it went down to 20% or 15%. But that's a lot of patients with incontinence for some months until it got better. My interpretation of this is that the dissection of the apex was carried out mechanically with the scope, without looking at the sphincter, without realizing what was happening. And of course, this curtain was developed by the action of the endoscope going up and dissecting the lateral plane. And then, of course, the curtain had to be cut. But of course, this curtain comes from the sphincter itself. So it is a de-epithelialization of the sphincter. And in my opinion, when you do that to the sphincter, it cannot do the watertight seal function until the mucosa grows back after some weeks or months and regains its functionality. So the first technique that was published in 2008 by Endo was this anterior-posterior dissection HOLEP. This technique started at 12 o'clock, let's say, to dissect downwards. So it was very different from the original dissection. And as you can see, there was an amazing improvement in the rate of stress incontinence after the operation. It was a relatively small series comparing their results with the classic technique. But again, it was largely ignored. It didn't have a lot of impact, and people got, still were obsessed with the three-lobe technique. Then Thomas Herman described THULEP in 2009. Up to that time, the thulium vapor enucleation was trying to take out three lobes, but many times not following the right plane and not always anatomically. But THULEP used a mechanical dissection with the scope, and it used the laser to cut fibrous tracts and to coagulate. And they described, let's say, the basis of a three-lobe enucleation technique carried out with thulium. They published a meta-analysis of randomized controlled trials comparing it to holmium, and they had a little bit less incontinence rate, but still significant. And here you can see again the mucosal curtain that we are discussing. Then Dr. Gong published his posterior start technique. So instead of starting at the bladder neck, preparing incisions, he would start dissecting at the apex, and then he would carry the posterior dissection all the way to the bladder neck. I think this was quite interesting, and but I thought it was a little bit crazy, because in the large glands that might be a little bit difficult. And then he would do a two-lobe enucleation, trying to follow again a similar method of dissection, anterior, so posterior, anterior dissection of the apex. So interesting contribution. Then Miernik presented the three-horse shoe-like incision in 2018, and here he was also starting with this dissection around the verumontanum to find the plane, and he would carry up the dissection laterally again, blindly. So here you can see the infamous mucosal curtain again. And then he would do another horseshoe incision in the bladder neck to finalize the procedure and dissect the prostate this way. So an en bloc technique with 3 incisions, but still the dissection of the apex was following the classic approach, and also the incontinence results were similar. We described in 2014 this green light enucleation technique. It was very similar to Hiraoka's original description, but we reflected about this white line. If you cut the mucosa at the apex before you start the operation, you're going to prevent it from breaking in another area when you do your dissection of the apex. And we observed very low stress incontinence rate despite carrying out a mechanical enucleation of the prostate. And this has been corroborated by many groups who have published their series of green light enucleation. The rate of incontinence is very low, and that's quite interesting. Of course, Scofone presented the en bloc no touch technique in 2015. It was an en bloc technique, but it started with an incision, a classic incision, and then it would try to remove the prostate en bloc. But again, you see the infamous mucosal curtain in one of these graphs. So again, as you can see, people have been trying to contribute with different ideas, and we have been evolving slowly, trying to improve what we do. The en bloc technique with one lobe was probably faster. It had some advantages, and the no touch technique was a new concept that you should avoid touching the technique with the laser. And here in 2019, Scofone reflected even further about how to perform the apical dissection to preserve the mucosa in the sphincter, because we are now recognizing how important this is if you want to get immediate continence for the majority of your patients. 1 year before that, we published this en bloc technique of holmium with early apical release, which was a continuation for us of what we were doing with green light enucleation. Of course, we had to adapt and develop some ideas and tips and tricks to use a straight firing fiber to do the en bloc technique. And we found out that it was a very fast technique with very low rate of stress incontinence, and it keeps getting better. This is a series of 80 patients that we followed up prospectively with Moses holmium, and we found out that the rate of stress incontinence was very, very low after 1 month. Thomas Herman published the TULIP updated technique in 2019, and of course this shows a new development of, or an evolution and different reflections on how to TULIP uses blunt anatomical dissection, and it denies the importance of the energy source. It's more an anatomical concept. Then this technique by Ito, the complete en bloc with direct bladder neck incision technique. What they do is they find the plane at the apex, and then they progress very fast to the bladder neck, and then they continue the dissection clockwise until they cut the last attachment laterally. And they have also reported relatively lower rates of stress incontinence rate, but this is just showing how vibrant this field is in urology, that there's new ideas coming up all the time. And again, this publication by Lin also compares different en bloc ideas, and they look at the incontinence rate, and they find that 3 incisions with some modification from the other technique that we discussed before, where they score the mucosa at the beginning, will give very low incontinence rate. So they recognize that this technique is very similar to what we described with the white line and the early apical liberation. And finally, there's a new concept that Thomas Herman is pushing, the preservation of the 12 o'clock mucosa. There is some anatomical background to this with techniques that have been described for robotic adenomectomy, where the urethra is preserved. So inspired by this, Thomas Herman has described this idea, but we still don't know if it has any advantage in terms of continence or bladder neck stricture rates. But of course, we are exploring new ideas all the time. So to me, the idea that is showing in different papers, different groups, and their data is that if you do a careful apical dissection and you try to preserve the sphincter's mucosa, you will get low rate of early stress incontinence. So as you have seen, there's many contributions trying to improve the outcomes of endoscopic enucleation. There is recent surgical technique refinements that make endoscopic enucleation of the prostate a very attractive option for the treatment of BPH, and I think now it's the time to learn and do it. I have personally uploaded more than 30 real-time videos, real-life cases, which means that they're not so cherry-picked, you know, that when you see them, you find them, they're perfect, but they reflect the reality of the technique we described on the early apical liberation. So if you're interested, I would be very happy if you visit and comment on these ideas. So thank you very much for your attention, and I will be happy to answer questions when the time comes. Thank you.
So thank you, Fernando. This is a pre-recorded presentation. Fernando will join us for the Q&A section at the end of this webinar. So it's a pleasure for me to introduce Giorgio Bozzini, that we talk about laser technologies for enucleation. What's next? Giorgio, please.
We have listened to a very nice presentation from Fernando. It was focused on all the technique that we have in our hands to perform a very good enucleation. Now we will shift the laser technology for the enucleation. We have different energy source to perform a good enucleation. So next, I have nothing to disclosure, and we can go to the next slide. In the next slide, you will see that, as already Fernando said, holmium as the gold standard for laser enucleation. So we have plenty of publication about holmium enucleation. Beautiful. So what are the most important features of holmium? We have a depth of colligation 0.3, 0.4 millimeters. The chromophore is the water, the saline, and usually we have a pulsed emission. So there's like a shock wave that make a good detachment from the adenoma and the capsule. And we have holmium. We know him very well. There's a lot of papers written on the argument, and in the next slide you will see that this is the equipment you need. So you need a laser source, you use a front fighting fibers, usually for a good holmium enucleation 550 is the right one to be used, then a resectoscope, and then a morcellator to get all the fragments out from the bladder. Next one. Lot of papers has been published about holmium enucleation, and so this is why we can use holmium enucleation for prostate that are bigger than 30 mL, and it became gold standard over 80 mL. Next one. Then we have thulium. Thulium is the little brother of holmium, so we have a wavelength that is nearly the same of holmium. You need saline, so the chromophore is water, and here we have a continuous emission, while the emission in the holmium was pulsed. Here the depth coagulation is more superficial, so it's 0.1, 0.2. Next one. Here we have the same equipment. The only thing that is changing is the laser generator, that is a thulium laser generator and no more an holmium laser generator. And then we have a fiber. Usually you can use an 800 micron diameter, which is a little bit bigger than the holmium one. The same continuous flow resectoscope and the same morcellator. Next one. Here we have a short overview on the thulium use. It started as a tulip and then it became the tulip. So the technique is slightly the same of holmium. So you need to enucleate the adenoma from the capsule. In the holmium, you have an interaction in between the energy and the tissue that is like a shock wave, like an hammer that makes a separation. And here with thulium, you have like a knife. It's something that detaches because it cuts and coagulates. Next one. We have a lot of literature about thulium. Not that one has holmium, but in the first papers, what we can say that is slightly the same with less blood loss, less complication, less catheterization pain and hospital stays. But, next slide, we actually need much more cases, much more literature, much more papers to understand if thulium can act exactly the same as holmium. And this is why in EAU guidelines you have weak recommendation and nothing that can be seen as holmium ones. Next one. Then we can shift to green light enucleation. The source change, we have the green laser, and we have quite the same resectoscope, but next one. Here you can say that the preorientation depth is deeper than the two others, is 2 times holmium and 4 times the thulium one. The chromophore is no more the saline, but is hemoglobin. The emission is continuous, like thulium, and the wavelength is completely different from the holmium and thulium. And it's green light because it enters the visible spectrum of light. This is why you see the green light. Next one. It started just in the meantime. So first was holmium, then thulium, and then green light laser enucleators start to doing enucleation. We have no RCT available on this technique. Next one. And then we can shift to a newborn laser, is the thulium fiber. So thulium fiber was born to treat and to dust stones during our retrograde intrarenal surgery. But it can be used also like a thulium low energy power generator. Next one. So what is going to happen? With thulium fiber, you can use it pulsed or in continuous. It's just the same. You can shift from one to another. It is considered inside the guidelines as the same one as thulium. And starting from 2019, so 2 days ago, it was started to be used as a TFL enucleation and can be done with the same technique as thulium or holmium and can be used the same way. Next one. The last laser I want to tell you is the diode laser. Is completely different from the one we considered. There are different variety of wavelengths, so it covers a long part of measure. The absorption coefficient in mainly melanin, the emission is continuous and is a 2 deep laser. This is why it can be seen as a dangerous laser if you think about enucleation. Why? Because you need to find out a correct interaction between the laser and the tissue, thus to have a good enucleation of the adenoma and also no problem on the capsule. Next one. There are some little RCT on the DLAP, so the enucleation with diode, but the results are slightly contradicting because it depends mainly on the operator, and laser is the less safe according to what we know about laser. Next one. Based on these, the only straight rating we can find on diode laser is weak, absolutely weak. Next one. So, what we need to expect from a good enucleation of the prostate with laser? Next one. So, we need to expect that the gold standard currently is on holmium, but as I told you, there are very good results on thulium, and the green light enucleators are going up and up. They need thulium need literature that cover a period more than 3 years of follow-up. Actually, green light laser need something about RCT. Next one. Now we can say that HOLEB has come of age, is well established, like TURP 20 years ago. Next one. TULIP is a very valid alternative and needs something more than 3 months of follow-up, but can give you some good tools. One of those could be the ejaculation sparing technique. Next one. Because it's the only that cutting and without enucleating can spare a little area around the verumontanum. Next one. For enucleation with thulium fiber, we need papers. We have started just yesterday doing this kind of enucleation. We need RCT to compare TFL with holmium, with thulium, with TURP. So we need probably a lot of papers to say that thulium fiber is very good on dusting stone during our retrograde intraoral surgery, but also we need a lot of papers saying that a low thulium energy enucleation is the way to go. Next one. Green light is still under investigation after 11 years. They are improving and improving, but actually there are no big data that say that can be compared with holmium on thulium. And the real question is, should we persist on that or not? Next one. The DLAP actually is very, very difficult to come to a numerical conclusion. Sometimes you have very good results, sometimes the results are very poor. And RCT are really needed. But actually, as a take-home message, we can say that we can do very good enucleation with very good results, surely with holmium and thulium. TFL can play an important role because it's a low energy thulium. Diode is quite controversial. Green light needs more cases. Next one. Thank you very much, and I hope my presentation enjoyed you.
Thank you, Giorgio. The next speaker is Christopher Netsch. Let's talk about the clinical results in terms of AEEP. Please, Christopher, the floor is yours.
Thank you very much for this nice invitation. So I have to share my screen, just one moment. So I hope you can see my screen. So I heard a lot about enucleation techniques and different lasers, and so now in the next 15 minutes I try to to give an understanding of which energy sources at which power levels they should be used. So this is my conflict of interest. And so first of all, we all heard about the AEEP, the anatomic endoscopic enucleation of the prostate. More or less, it's an endoscopic Friar's procedure. So this we just do the same as an open prostatectomy with the finger. We do it with the beak of the resectoscope. And here you see a lot of acronyms for these procedures, depending on the energy source you use. If you use holmium lasers, thulium lasers, diode lasers, green light lasers, bipolar, monopolar energy, eraser lasers, and so on and so on. So the first paper was from the initial AEEP technique from Peter Gilling and Mark Fraunhofer from 1998. It was the HOLAP technique, the holmium laser enucleation of the prostate. And they used a holmium YAG laser with the laser energy of 2 joules at 40 hertz. This was the initial power settings they used. So, so when we talk about different lasers, we have to talk a little bit about the physics of the laser. And here, it seems a little bit complicated, but what I want to show you is the wavelengths of the different lasers and the penetration depth in tissue and the absorption coefficient of the different lasers. We first have here the green light laser with a wavelength of 0.5 micron, and holmium lasers and thulium lasers with a wavelength of nearly 2 micron, depending of whether it's a YAG laser or it's a fiber laser, because fiber lasers wavelength is 1.94 microns, and YAG lasers is about 2.1 microns. So the most important issue here is that YAG lasers, thulium YAG lasers and holmium YAG lasers are highly absorbed by water, and as prostate is a watery tissue, the penetration depth is very shallow of holmium YAG lasers and thulium lasers. So here it's as Christian said, it's 0.8 for the green light and 0.4 for holmium and 0.2 for thulium lasers. And this is an important issue in enucleation techniques. So the next slide is about what we have to know about using lasers, about the holmium lasers. We have to talk about low power, high power lasers with short or long pulse modes, about the Moses effect, and if you talk about thulium lasers, you have to talk about continuous wave lasers, about pulsed lasers, because now we also have the pulsed thulium YAG laser and the super pulsed thulium fiber laser, and this makes a difference in the working mode of the laser, because it works more or less like a holmium laser. It's the pulsed thulium lasers are mimicking more the holmium enucleation effect than the continuous wave thulium lasers. And finally, I want to talk about the green light laser and how they work. So the initial question is how much power is really necessary for the HOLAP procedure. As I said, first, it was about 2 joule at 40 hertz in the initial publication, but how low can we really go without compromising the results? This is a question that an open question that was tried to answer during the past 13 years. So why is this an important question? Because of course the initial capital equipment cost is significantly different whether you buy a 50-watt holmium YAG laser device or a 120 watt holmium YAG laser device, because you can say that estimating that 1 watt of laser power is about €1,000, and then you can see that there's a significant difference between a 50-watt machine and a 120 watt, 150, 180 watt machine. So there some discussion about the potential negative effects of high-powered holmium lasers on post-op dysuria, incontinence, LUTS, and then the erectile function. So this was the idea behind using low-powered lasers. So the first low-power HoLEP series was by Jens Rassweiler in a German magazine in 2008 using a 40-watt device, and the working group of my department again used the same laser about 10 years later, and the feasibility and also the good results of these two studies showed that you can also have good results using just a low-powered laser. So there are also some retrospective studies analyzing different groups of laser power, because the series before were just one arm series with no control group. But here this is a series from 2020 from Turkey, and they try to compare high power with higher powered settings at the apex, and analyze the efficiency of it. So the first group was about 20 watt and the second about 37.5 watts at the for enucleation and hemostasis at the level of the apex. So they found, and also they used the long pulse durations for hemostasis and shorter pulse duration for the enucleation mode. So the results were, of course, that the high-powered group were better in terms of enucleation time and catheter removal time and hemoglobin decrease, because of 20 watts is really, really less for the apical area. So there are also some prospective randomized trials who try to compare low power with high power HoLEP. So again, they used 50 watts versus 100 watts, 2 joule at 25, comparing with 2 joules at 50 hertz. And another series from this year also, they said that 50 watts was here medium powered HoLEP compared with 100 watt HoLEP. So the conclusions of these studies were that there were no differences in dysuria, incontinence rate, peri-op, or urodynamic parameters between the groups. So low power or medium power HoLEP was non-inferior to high powered HoLEP, but of course not superior. So the use of it is questionable. So, and to I must say, in most of these low-powered HoLEP series, the intra-op use of electrocautery for coagulation issues is unclear, and you cannot find a proportion of in which persons electrocautery was really used for coagulation issues. So one important thing is the Moses effect. In one new issue is the Moses effect, because this really makes a difference in HoLEP surgery. What is the Moses effect? to make it very short, here you have a physical explanation, but maybe it's easier to say you have a bubble and you send a second bubble through the first bubble. This is what you see in the left diagram. That means that the energy is more precisely for enucleation and coagulation issues. In terms of that, Nivo et al. Published a randomized trial in the British Journal of Urology. And what they are doing a prospective randomized trial comparing the Moses technology with the standard technology of HOLAP. And they used 2 joules at 40 Hertz for enucleation and 1.5 joule at 30 Hertz for hemostasis. And they do the left lobe or the right lobe with the Moses technology and the other lobe with the standard technology. So what they find, this is an important issue, that the fiber degradation was less with the Moses technology. And in expert hands, we have a shorter enucleation time, a higher enucleation efficiency. Of course, this is due to the shorter enucleation time compared to the non-Moses group. And this is also important, the hemostasis was significantly shorter in the trainees who participated also in this study. So let's talk about thulium lasers, for what we are using for thulium vapor enucleation. The initial description of the thulium vapor enucleation technique, there the thulium laser, it was a continuous wave thulium YAG laser, and it was used at 70 watts. We also performed the thulium vapor enucleation at 90 watts. This is the standard setting in my department for the last 11 years, and we have very good experience. But we also used the 120 watt laser and the 200 watt thulium YAG laser, but for enucleations, enucleation technique, this does not have really advantages. So much power is just for vaporization issues, but not for the enucleation technique. So the THULAB technique, it's a blunt enucleation, and the enucleation technique with the peak of the instrument, just using the laser for incision and for coagulation issues. Here it's a little bit different because Thomas Hermann used 30 watts for coagulation. This is different to the THUWAB technique. We always use 90 watts for enucleation and coagulation. So what's next in thulium laser enucleation? We have the superpulsed thulium fiber laser, and Dmitry Enikeev from Russia first published the series in 2018, and he used 1.5 joule at 40 Hertz, nearly mimicking the HOLAP technique and the HOLAP effect, because it's a pulsed thulium laser, it's a fiber laser. And now for about 1 year, we also have the a pulsed thulium YAG laser. And here we have published in the virtual WCE in 2021, and for the next year, the setting of 0.5 joule at 200 Hertz. So it's also possible, and you can also enucleate with pulsed thulium lasers. So what about green light lasers? In green light laser enucleation, you find different energy settings depending on the laser fiber you use. If you use the MOXIE fiber or the 2090 laser fiber, then you use different energy settings. But for the enucleation, you use the enucleation power at 120 watts. But if you use the green light, you have to reduce the energy at the level of the apex because of the high penetration depth of the green light laser compared to the holmium and the thulium YAG laser, as I said before. The green light vapor enucleation technique was described by Elschaber in 2015, and they also used different energy settings at the bladder neck and for the adenoma. However, they did not describe the energy at the level of the apex they used. So as green light, holmium and thulium lasers are the most important lasers for enucleation. I did not make a literature research for the other energy sources, for diode lasers and so on, because they are not really used as in many clinics, and they have no really impact. So my conclusions are for HOLAB. So 23 years after Peter Gilling's description of the HOLAB technique, we are just at 2 joule at 40 hertz, and it's still the standard setting. The advantages of low power HOLAB are less clear than we are thinking of, and the power settings of the low power HOLAB is not really well defined, because also the usage of electrocautery is less clear, because if you do it at very low power and you finally have to use the electrocautery in every case, then you can also use high powered HOLAB settings. So Moses 2.0 it's a very important development, because it means faster enucleation at a very good hemostasis, and also the day case surgery. I have no data shown here, but for day case surgery, the Moses laser is a very good tool, because the hemostasis with this laser is very efficient due to the Moses effect. So for thulium lasers, we have continuous wave thulium lasers for thulium vapor enucleation or laser enucleation. You can use it with 70 to 90 watts very efficiently. For the super pulsed thulium fiber laser, we have this setting here, 1.5 joule at 40 hertz. For the pulsed thulium laser enucleation, here you can see the energy setting, but for the last two techniques, for the pulsed TUF-lab technique or THULab technique, we have very few studies. We need more experience and more prospective studies. For the green light laser, for green lab technique, it's a different laser compared to the holmium YAG or thulium YAG laser. Because of the high penetration depth, you have to be very cautious at the level of the bladder neck and the apex. So now I'm finished, and thank you for the attention. Thank you.
Thank you, Christopher. So the next presentation will focus on the dark side of the moon, the dark side of AEEP, because learning curves may be steep, and sometimes initial results may be discouraging. So Professor Tunc, tell us something about learning curve, training models, and programs, please.
Hi, everybody. My name is Tunc. I'm a urology professor in Acıbadem University in Ankara. My topic is, my presentation topic is learning curve training model and the programs. HOLAB was described in 1998, as you know. In 2015, laser enucleation was said to be the gold standard in BPH surgery. Why this technique ain't spread so much, even though we were in HOLAB age? Publications are an indication of the spread technique. And here you'll see the publications by year. Don't you think that there is a big challenge here? Much fewer publications available than expected. There must be two reasons. First, it might be incorrect technique or not well understood. I think it has very satisfying results, both for the patient and the surgeon. but it has not become widespread by clinicians due to some difficulties. What are the difficulties? This question was answered by Dr. O in 2019. The authors researched the techniques in the literature and concluded that none of the newer techniques have been accepted as a standard technique for HOLEP. So the main problem is the absence of a standard technique. There are many dilemmas and misunderstandings in this field. I suppose that you agree with me that there are many questions which are waiting to answer. Even in guidelines, there are some controversies for BPH surgical treatment, as you know. Laser enucleation is clearly recommended regardless of prostate size in EUA guidelines, while it based on prostate size in EAU guidelines. There are still controversies about size dependency. I can honestly say that laser prostate surgery is followed by an inconsistent path due to the industry's impositions and the confusions of the doctor. For example, if you have a thulium laser in your hand, you can use it for vaporization, vapor enucleation, complete enucleation, anatomic enucleation, depending on the machine's power. Unfortunately, the industry and the doctors have not been able to decide which laser and which technique will be used. There is a big mistake in this field. First of all, we should have a common idea. We are focusing on surgical equipments rather than techniques. There is a big mistake in this field. First of all, we should have a common idea. According to the literature, you can see different kinds of terminology for neck enucleation, such as complete enucleation, anatomical enucleation, vapor enucleation, and etc. Why do authors need to use different terminology? There is only one reason. The meaning of anatomic endoscopic enucleation is not well understood by surgeons. According to the literature, we see HOLEP, TULEP, GreenLab, thulium vapor enucleation, thulium fiber enucleation, TUFLEP, and etc. And don't forget, the anatomical enucleation that makes the surgery unique regardless of the energy source. Perhaps this is the most important issue to be solved. We need a common terminology like laser enucleation of prostate, or we can include monopolar and bipolar enucleation and name it anatomic endoscopic enucleation of prostate. In my opinion, we should do anatomic enucleation no matter which laser energy source we use. As you know, for a proper technique, we need anatomical landmarks and standard steps. There is no consensus on this issue yet. When we investigate the details of these current techniques, for example, they based on prostate shape, early release of apical mucosa, 12 o'clock dissection, ejaculation preserving, and combinations of them. Steep learning curve is not only the problem. The main problem is the absence of the perfect model for learning. For example, here you see the prevalence of HOLEP in the United States on this map. There are different colored dots. The size of the dots indicates the rate of HOLEP performed at that site compared to other BPH procedures. You see some of the centers left these surgical procedures in time. Why they left it in a time should be questioned very well. So we need a standardization of enucleation of prostate. Because of this reason, we present the project to ESUT board in Leipzig 2020. The project was approved by the members. The purpose of this curriculum is basically the standardization of the technique and shortening the learning curve of enucleation as much as possible with less complication rates. As you can see, these are the experts who worked on this project. You see the draft curriculum. It's also a developing and living curriculum. definition of standardization of enucleation technique, experts and training centers, and etc. For the standardization of enucleation technique, we agreed to use Delphi method to develop most efficient technique. 41 experts attended to this study. The questionnaire form was developed by this study group. 24 questions were asked to the participants to evaluate the instrumentation, energy sources, enucleation steps, energy sources preferences, and complications and their management. This project is basically aimed to teach and spread laser enucleation of prostate by surgeons who experience in this field within standardized program. Here is learning curve graphic. You'll see the slow beginning, steep acceleration, and the plateau points. Proficiency defined just where plateau started. The graphic is important because, as you see, slow beginning and learning of this technique makes surgeons to abandon this technique at initial cases. What are the concerns and challenges about this technique? Yes, learning curve is long when we compare it with laparoscopy or robotic surgery. In my opinion, is it harder than QRP to learn? In my opinion, the mentality of QRP and the endoscopic enucleation of prostate is completely different. We cannot compare these two techniques. It's interestingly, this study shows HOLEP is not harder to learn comparing to QRP. Different studies defined different plateau points so far. Here you see Placer et al. Gives 50 to 70 cases. And the second study, 60 cases. And you'll see a meta-analysis that was published in 2018, 20 to 60 cases, and it review an article, 30 to 40 cases. We can say that the average case count you need to reach is 30 to 40 cases. And here you see a systematic review of endoscopic enucleation of prostate learning curve. They included 70 articles containing a total of approximately 4,060 cases performed by 76 surgeons. And here you see usually 30 to 40 cases are recommended, but Dr. Kine et al. Recommended more cases than usual. Here you see 200 cases and the other one 150 cases. In this study, they compared thulium fiber laser enucleation with thulium fiber laser and HOLEP and monopolar enucleation of prostate. TUFLEP is slightly superior to other techniques in learning curve because less carbonization and lower tissue penetration of thulium fiber laser. It seems to have correct surgical plane more easily. The other concern for this surgery is the fear of incontinence. According to the literature, incontinence rate is approximately 20%. The relations between the rhabdosphincter and the prostate is not well known yet. And there are some difficulties for this surgery. First, lack of 3D view. There are some complex endoscopic head movements we need head movements for this surgery. It's not easy to explain it, but it should be seen. I recommend to the beginners to stay in OR with the mentor for tracking. There are some anatomical variabilities, as you know, size, shape, nodular density, and vascularity. For example, in case of high bladder neck or large prostate, it's difficult to complete the enucleation of prostate. Sometimes we need to slice the prostate. For beginners, there are some training models. First, self-taught. How can you learn and start to this surgery? Self-taught many surgeons are self-taught. Multiple ways in the literature, and each model each method has their own success rate. Illustrations and animations and videos are useful also. He strongly recommended watching a large number of real-time operation videos, because before starting this surgical method, those mentally absorbs the main steps and landmarks of the surgery. It's really hard to understand what mentor doing when you don't have any idea of what is going to happen next or what he mean to do. Especially in cases where visualization is impaired, such as bleeding and similar conditions. For this reason, it's more appropriate to create a certain landmarks in visual memory and then watch experiences in live surgery. Tracking in OR is more effective than watching videos, because during this surgery, we usually use hand movements and do blunt dissections. Dressler et al. Evaluated a system for a non-invasive quantitative motion tracking to recognize differences in the movement pattern of experienced surgeons and beginners. And experienced surgeons and beginners were recorded during HOLEP respectively. A mean lever angle of individual normalized motion patterns was considerably lower in the advanced than in the beginners group. And interestingly, the hand movements are similar with the laparoscopic surgery. This is our study about our role of laparoscopic experience on learning curve. 80 urologists who performed HOLEP answered our questionnaire. 47 of them declared that they completed learning curve before 20th case. So we saw that experienced laparoscopists complete the HOLEP learning curve earlier. The reason for this may be the common points of laparoscopic procedure and HOLEP surgery, which are 3D imagination, separation of anatomic plans, blunt dissection. And for this surgery, fellowship program is more important. As you know, there are many benefits of fellowship on learning curve: high case volume, stepwise learning, chance to see difficult and featured case, reducing complication fear. And this is a study about learning curve. This is a survey of the topic here. You see a survey of fellowship trained HOLEP surgeons and their current practice patterns. Survey questions focused on the following components: the experience of the learning HOLEP, difficulty ranking for each step of HOLEP, the experience of training others in HOLEP, and the three most challenging steps to learn were as follows: the joining of the anterior and posterior planes, the apical enucleation, and encircling the lateral lobe to 12 o'clock. And 13 respondents participated in over 20 cases during training, while 9 participated in over 50 cases. Only 6 didn't complete a case from start to finish while in fellowship. 75% practice HOLEP currently, and 25% of them teach to trainees. Mentoring plays an important role in learning curve. This should be known that laser enucleation is anatomic enucleation process. 3D imagination of surgical notch and recognizing prostate capsule as a landmark is very important. In case where visualization lost because of hemorrhage or surgeon lost the control of the surgical plane with any reason, a mentor accompanying the surgeon and will reduce the TRP conversion rate and prevent the surgeon from breaking her confidence in this technique. And there's another study. The authors concluded that complications are more common in the first 20 to 30 cases, especially the TRP conversion is mostly seen in this early period. With careful patient selection, it takes 50 cases to reach the acceptable efficacy. With mentoring, it can fall to 20 cases or fewer. And here you see a study about mentoring. They compared one self-taught surgeon and one whom he trained for HOLED. This shows us how mentoring affects on initial cases at the same time. Post-operative results of surgeon 2 are comparable to surgeon 1. Overall, adverse effects are significantly less in cases of surgeon 2. And proper patient selection is very important. I recommend that for the beginners, please try this technique over than 30 cc prostates. Don't try to do it less 30 cc prostates. The other training model is simulators. Here you see Virtamet Uracim is the first defined virtual reality training model for HOLED. This system allows the trainees to experience the surgical simulation and perform enucleation maneuvers through the virtual reality. The device has a system that can provide tactile feedback to the surgeon's hand. It also gives some information about sphincter injury, surgery efficacy, and resected adenoma percentage. In this simulator, there is no real laser and no real irrigation fluid. These are the disadvantages of this model. Here you see another training model, bench top model. This is the wet bench top simulator developed by Kansai Medical University. A 20 watts real holmium laser is used in this model. The use of real instruments, real fluid irrigation, observation of tissue laser reaction with a real laser, and more realistic tactile feedback are the factors that make this model stand out. And OSTEC, the OSTEC batch model, Asian Urology Group produced this model. They use Turkey gizzards and ex vivo model, and parallel muscle fibers of the gizzards are an ideal model for enucleation. And but as you know, repeatability is important for standard results. We cannot achieve this with simulators, but fresh cadaver is the most realistic model. This is a study about cadaveric training model. Whole procedure was performed on fresh cadaver, and a video record of this procedure has been taken. This video and 10-point Likert questionnaire distributed to the acid group, and 26 colleagues returned. Lack of tissue reaction and absence of bleeding stated as a disadvantages. As a conclusion, complication rates are not higher than the traditional techniques. So don't delay to learn. Proper patient selection for initial cases is very important. Prostates less than 30 cc is not recommended for the beginners. Mentorship plays a really important role on learning curve. In initial cases, certain rates of complications can be expected. Mentoring will be helpful to avoid this. Watching real-time videos of expert surgeons helps understanding steps of the technique. Simulators are helpful in training programs. fresh frozen cadaver model is the perfect training model. Thank you very much.
Thank you. Thank you so much for your presentation. I think that we can start the discussion section. I see that all the presenters have already enabled the camera. So I would like to start the discussion with a very quick round of questions. I would like to say, what is your preferred technique and source of energy for the beginner, for teach AEEP for your residents, for example? Fernando.
Hello. You can hear me, I guess.
Yes, yes.
Yes. Okay.
Perfectly.
So, yes, I think all these models for practicing in the cadaver and things like this are a little bit complicated. In my experience, the best way to learn is to visit someone who has a lot of experience and stay there for a while. So if you watch 30, 40 cases, when you have to sit down and do a case, you will be much better prepared. And this is probably applicable to every technique. What I teach is en bloc technique, usually with holmium. And when people come and watch many procedures and then they try to do it, the ideal situation is that they do it mentored. And if they are mentored, I think they can very fast get a grasp of HOLEP. It's not a difficult technique to learn when you know what to expect. So this is a crucial step, in my opinion, to watch many, many cases.
Thank you. Giorgio, what's your opinion?
I can tell you that I feel more comfortable to let a trainee start with thulium, because you can use the same technique as holmium. If you feel into trouble, you can vaporize, and then if you have any problem in enucleating, you can vaporize and then give a disobstruction to your patient. And the power of coagulation is a little bit better than holmium. But the suggestion of Fernando to watch a lot of procedure and being mentored anytime is a good option too.
Okay, perfect. Thank you. Lucy, what's your preferred approach? Free lobes, en bloc for teaching to your residents?
Okay. First of all, I agree with Fernando that watching several operations is the best way to learn this surgery. As you know, the shapes, M-lobe, 3-lobe, B-lobe, these are the shapes of these are the anatomical shapes of the prostate. So I like to do 3-lobe, but it doesn't matter. I don't see differences, superiority or disadvantages or advantages. It depends on the surgery. He or she can do whatever he wants.
Okay, thank you so much. So we have some questions from the audience. I think the vast majority of them is very interesting. I think that the question about stress urinary incontinence is interesting. So how do you manage stress urinary incontinence after all? How long does it usually last? Fernando.
Well, I think the best management is prevention, and I'm insisting in this because it was assumed with HOLEP that stress incontinence is something that could happen very often in patients. And what we did was to tell them that it would go away with time. And even some prestigious professors would say, well, this is because the sphincter has not been working for some time. And when we do enucleation, it has to get some tone and things like this that were a little bit esoteric. And I have to say, when some groups get rates of stress incontinence in the region of 2-3%, after 1 month, and others get 30%, there must be a difference. You know, this mechanism probably doesn't apply. So I think that the first step is prevention. It's very easy to adapt your technique to protect the sphincter, regardless of if you use 3 lobes, 2 lobes, 1 lobe. So I'm just calling for surgeons who have incontinence to try to prevent it. Of course, if it happens, then you have to use the usual approach for patients. Of course, reassure them that it probably will go away after some months or weeks. And then, of course, pelvic floor exercises will help. Avoiding, coffee, tea, because often these patients could have a mixture of stress incontinence and urge incontinence. You can use duloxetine, which sometimes help increasing the tone of the external sphincter. So, and then, of course, if after 6 months they don't improve, then you can, and it's severe incontinence, then, of course, you can think of other approaches, my opinion.
Thank you so much. Giorgio and Lufti, some suggestions, some difference?
Yeah.
What Fernando says is more than correct. And how to prevent it? What I do is the release as soon as possible the mucosal apex from the adenoma. So anytime you push the adenoma towards the bladder neck, you don't make any stretch of the sphincter. This is the best way to prevent the incontinence.
How do we prevent the sphincter or stress incontinence? I think that during this surgery, it's not easy. It's not easy to destroy, to make a damage to the rhabdosphincter. Actually, we destroy the stabilization of the rhabdosphincter. According to the literature, you see that the rhabdosphincter striated muscle fibers extended toward the bladder or the prostate, and especially at 12 to 1 o'clock position, these striated muscles penetrate the stroma, and it means that the rhabdosphincter fixation during this surgery, if we can leave a leaf at the anterior part, I mean 12 to 1 o'clock area, this makes the stabilization of the rhabdosphincter. So the main important point is we have to leave a leaf at that point, at that position.
Clear, very clear, thank you. Again, from the audience, what do you think about the ejaculation sparing technique? Do you think that it's possible to combine ejaculation sparing technique and the EEP? Or it's not possible? First question. Second question from the floor again. Is there any difference in retrograde ejaculation rate between laser enucleation and TURP?
Well, if I may, there is a paper by a Japanese group, I think, where they tried endoscopic enucleation with trying to preserve ejaculation, and they managed in about 45%. And this is my personal experience as well. We try it in very motivated patients who, at the same time, are ready to take some risk for ejaculation in exchange for a durable procedure. And it's about half of the patients who can preserve ejaculation. We don't understand the mechanism properly, and we don't understand the landmarks to be able to preserve ejaculation systematically in these patients when you combine it with enucleation. And the second question was,
what is your technical tip?
Well, you have to try
tip?
You have to try to preserve, of course, the ejaculatory ducts. So you don't cut the ejaculatory ducts, because sometimes with HOLEP you do, and you see them open. And in this case, retrograde will be very, very, of course, it will happen. And you can preserve the hood that surrounds the verumontanum. So it has been described for TURP, and there are some papers out describing how it can be done. Regarding the rates, of course, when you do HOLEP, without caring for the ejaculatory ducts or the ejaculatory mechanism. I think the rates of retrograde ejaculation are super high, so probably almost every patient.
Giorgio, if I remember well, you have a huge experience in terms of ejaculatory sparing technique and ejaculatory sparing procedure. Tell us.
Well, the key point is to understand that instead of preserving the bladder neck, that was the previous concept of 25 years ago, is to preserve the apical area, so the area around the verumontanum. Is just underneath the verumontanum is the area where the old ejaculatory muscle that starts from the vesicle and arrives just at the apex. So you spare an area about around the verumontanum and the two little heels just at the apex, so preserving some prostatic tissue. That was not my idea, but the idea of Alusi that published this in 2014 on the Journal of Endurology. These can be more easily done with thulium, because with thulium you can actually cut the prostatic tissue instead of holmium or other laser that detach and make shock waves. So preserving the area around the verumontanum is the key point in motivated patient, in younger patient, to preserve ejaculatory function.
Thank you. We did not talk about the B-polyp, but there is another option for perform a good EEP. What's your opinion, Professor Tunc?
You disconnected your microphone,
Yeah.
Christian.
Thank you.
Sorry.
About the B-polyp.
B-polyp, yeah. I have no experience for B-polyp, but I believe that for large prostates and at the level of bladder neck, it's not easy to complete it. Maybe at the level of the prostate, at the level of the bladder neck, we have to do resection at that level, because otherwise it's not easy to hold the prostate. But I have no experience for BLAP.
Okay. Thank you. Another question from the audience: when you perform a OLEP and then you have a positive diagnosis of cancer, and you have to perform a radical prostatectomy, is more difficult radical prostatectomy? Is it feasible? We have a higher risk of positive rate of positive margin, or is the same? What do you think about this?
Well, we have performed a number of robotic prostatectomies in patients who were previously submitted to HOLEP, and I would say that in general it's a more challenging procedure. I'm not aware of data looking specifically into this matter, but we have seen that patients tend to, the possibility of preserving continence is there, but the prostate is quite hollow, it's quite soft, and the development of the plane is a little bit more difficult sometimes. There is some variability, but it is feasible to operate these patients, but not a beginner's case, I think.
Yeah. Okay. Do you see some difference in terms of positive surgical margin or not?
We haven't looked into that yet. I think that is probably not so related to the previous surgery, but to the decision you make on the particular case. If you're going to try to go very close to the prostate, or you're going to get the wider margins, I don't think the fact that the central part of the prostate has been removed will affect surgical margins. It will be more based on the decision, the judgment you make on how you perform the procedure.
Okay. Giorgio?
Well, I quite totally agree with Fernando. Is a very wise suggestion. What he has said is completely my opinion. So I cannot add anything to
We agree. We agree.
ways.
Okay, Lufti, can you tell something about this? And then we move to the closing of this webinar, I think.
I have no many cases who had HOLEP or TULEP or TUFLEP. Then we did robotic surgery. So we don't have any data. So I have no idea.
Okay, perfect. Just the last question, because we have still 200 participants connected. So I think that our webinar is very, very interesting. It's a never-ending story. Low or high energy? Very short answer.
Well, if I may again, following the same order. Sorry, Giorgio. I think you can do HOLEP with any source of energy. If you know how to do enucleation, you can do enucleation with a spoon. You know, you can do with different wavelengths, different source of energy, different. It really is more based on the anatomical knowledge than the tool. My experience is if you're going to have a high volume of patients, the high power lasers give you probably more consistent hemostasis, especially Moses and virtual basket, you know, the pulse modulated holmiums. I have seen a recent thulium laser from Lisa, the HTL device with a HOLEP setting that has amazing hemostasis. So really, it depends. You can work with any laser. You can adapt to the laser you are using and get very good outcomes with low power and big power. But if you ask me, I would prefer a high power holmium and Moses or virtual basket.
Okay, perfect. Giorgio?
I can tell you that high power allows you to be faster. So high power, you are faster in your enucleation. Low power, you are a little bit slower. But with high power, if you are not that fast as you are expected, you can expertise a little bit more irritative symptoms. With low power, you lower down your irritative symptoms.
Okay, thank you. Lufti?
For anatomical enucleation, I totally agree with Fernando Gomez. You can use every laser in low energy or at low energy or high energy. But in my opinion, I like to use thulium fiber laser for enucleation. In my clinic, I have a thulium YAG laser or holmium laser, high power holmium lasers. But I like thulium YAG laser, thulium fiber laser, because there's no carbonization, there is no bubbles, big bubbles, and because of this reason, the VV is perfect. And I believe that during enucleation, we don't need to do. It's not necessary to use more energy, only for cutting the fibrotic bonds and making a coagulation. So the tip of the instrument is enough for enucleation.
Okay. Thank you so much. I think that our time is finished and we have to close this webinar. I would like to thank all of you because you were perfect in our presentation. I have to thank the organizer, the ESU especially, and thank you for the organizing this interesting webinar. And I have to thank all the attendees that are 200 at 8 o'clock. So I hope that they appreciate our webinar. Thank you so much and see you in the next time.
Bye.
Bye.
Bye. Thank you so much.